It's my pleasure to introduce Dr. Abdelmoein Al-Agha. He's a professor of pediatric endocrinology, King Abdulaziz University, Saudi Arabia. It was my pleasure to meet him here in Egypt twice in 2 conferences, and it's my third time to meet him again here online with Dr. Sameh Tawfiq. And I know he has a very big experience with growth hormone and growth hormone treatment, even the long-acting growth hormone. And I know that he published or introduced a paper there in SP this year, right? And we are going to hear from him a great lecture about the childhood onset of growth hormone deficiency, inshallah. Go ahead, doctor. The floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. My voice is clear?
Yes.
And,
yes, dear professor, yeah.
The slides also clear?
Yes.
Okay. Bismillah ar-Rahman ar-Rahim. At the beginning, I would like to thank Dr. Sameh Tawfiq, Dr. Mona Karim for their invitation. And as usual, Egypt and Egyptian doctors are always encouraging conferences, updates, and we are always pleased to meet our friends, colleagues, doctors from Egypt. And we feel that Egypt and Saudi Arabia is one country and their people are one population. Today, inshallah, I'm going to talk about childhood onset growth hormone deficiency. I will start from physiology, end up by latest update regarding growth hormone therapy. We start from beginning, and usually we start from physiology because always physiology is important to understand the presentation of any disease. Growth hormone physiology, as all of you know, that growth hormone is 191 amino acid polypeptide hormone, and it is secreted from antipituitary gland. The issue that the secretion is not like other hormones, it is in pulsatile fashion. That means we cannot, as a doctor, measure growth hormone for any child in any random way. We cannot do random growth hormone because it will be low. We need to know that it is impulsatile, so either we measure it in deep sleep, which is difficult, or by growth hormone stimulation test when we need to evaluate growth hormone secretion from the antipituitary. As any other hormone in our body under control, so all hormones in our body are under control, either by stimulating hormone, which is growth hormone releasing hormone from the hypothalamus, or from suppression from somatostatin that inhibits excess secretion of growth hormone. So the growth hormone will be imbalanced by induction and suppression. So we cannot normally, physiologically, you don't have a low or high growth hormone. There are environmental factors and other physiological factors that enhances the growth hormone secretion. And as all of you know that nutrition is very important. That's why in our children, we always encourage a healthy nutrition. We always encourage them to have exercise, because both nutrition, exercise, and early sleep, because growth hormone secreted during deep sleep. So 3 factors, physiological factors, we can encourage our children in order to have a normal growth hormone release, as well as a normal growth, nutrition, exercise, and deep sleep. Growth hormone, when it is secreted, it goes into the liver, and the most important factor that produced from the liver to enhance the growth is what is called insulin-like growth factor number 1. It circulates in the circulation and go into main sites of action, which is liver, muscles, bones, and adipose tissue. As I mentioned, growth hormone releasing hormone will stimulate the growth hormone release. Somatostatin will suppress ghrelin, which is released from the stomach. And now there is a good relationship between GIT and pituitary as well as hypothalamus. So many peptide released from gastrointestinal system has an influence either on pituitary or hypothalamus. For many of the hormones, one of them is ghrelin produced from the stomach. It goes and stimulates the growth hormone releasing hormone from the hypothalamus in order to increase the level of growth hormone. That's why fasting, the ghrelin produced from when somebody is hunger. So fasting is one of the stimulating factor to release the growth hormone. IGF-1, when it is high in the normal physiology, will suppress the growth hormone therapy. Thyroxine or thyroid hormone will stimulate the secretion of the growth hormone. That's why we cannot measure growth hormone or do growth hormone stimulation test unless we are sure that the child is not hypothyroid, because if the child is hypothyroid, the release or secretion of growth hormone from pituitary is blunted. That's why we'll get false negative results. So that's why thyroid hormone should be normal before we evaluate the growth hormone secretion. You can see how the pulsatile fashion of the growth hormone, and very important thing that they reported that growth hormone level undetectable more than 50 times of the day. So we cannot do random, because we might be unlucky if we did a random and we are in the period of undetectable levels. So the child will be false diagnosed as growth hormone deficiency, while the child is not growth hormone deficient because of false or wrong timing of growth hormone sampling. Should be always either in deep sleep, where you can see a peak of pulses in deep sleep and early hours of the morning, or should be by stimulation test. Of course, we cannot go to the child house to do it during deep sleep. So the only thing for us as a pediatrician or endocrinologist to measure it during by growth hormone stimulation test when we need to evaluate growth hormone deficiency. Factors that reduce growth hormone secretion: hyperglycemia. That's why we always, when we do growth hormone stimulation test, we ask the child to come fasting. As well as fasting will increase growth hormone. As I mentioned, ghrelin will enhance the secretion of growth hormone releasing hormone from hypothalamus. Aging, with age, the growth hormone level will drop. That's why growth hormone deficiency can be reported in adults as adult growth hormone deficiency. Obesity will reduce the secretion of growth hormone, will make a false low growth hormone level. Emotional depression, and high IGF-1 will suppress the growth hormone level. While ghrelin from the stomach, sex hormones, hypoglycemia, stress, exercise, sleep, all of them will increase and stimulate the release of the growth hormone from the pituitary. That's why we always encourage our children to do exercise, to have a deep sleep, early sleep, in order for them to have a good level of growth hormone. And this is what happens for growth hormone during our lifehood. We start from children, and the peak will start up until the child is adolescent because of sex hormone. Sex hormone will enhance the stimulation of the growth hormone, and then the growth hormone will be maximum till the epiphysis is closed, and after that there is a plateau stage, and then start to drop. They found that the drop is about 14% per decade. So every 10 years, there is a 14% drop of the growth hormone. That's why geriatric people, they suffer from the growth hormone deficiency. And some of the geriatric centers, they give geriatric patients a small dose of growth hormone to compensate for their low level. As you can see, the low level during geriatric age group and high level during adolescence. So there is a remarkable difference between adolescent growth hormone level and geriatric growth hormone level. And growth hormone, as I mentioned, will be converted by the liver and local tissue into IGF-1. And IGF-1 should be bound to IGF binding protein 3 in the circulation. IGF-1 cannot go in the circulation alone. It has to be bound by IGF binding protein 3, and the main complex, the one who facilitates the binding is ALS. ALS facilitates the binding of IGF-1 with binding protein 3. So the tertiary complex, IGF-1, IGF binding protein 3, and ALS, they go into local tissue to enhance the growth, and mainly bones, cartilage, and muscles. The growth hormone is not only for linear growth. Growth hormone has many benefits, provided that it's used in the right indication. Is not use of growth hormone. So a lot of people, when they see these good results, they make use of growth hormone. We always encourage the use, not abuse of growth hormone. Growth hormone has many benefits for the body. Increase protein synthesis, decrease oxidation of protein, promotes linear growth, increase bone formation and bone mass, increase active muscle mass, anabolic effect for the whole body. And growth hormone increase lipolysis. That's why it decreases the fat tissue and increases muscle tissue. So the lean to fat tissue will be reduced by growth hormone, opposite to a lot of population in our Arabic country. They thought the growth hormone will enhance obesity. They are thinking growth hormone has a positive effect on the height and positive effect on increasing the weight. And we said the opposite. The height will be increased and the weight or fat tissue should be decreased by growth hormone. Growth hormone never increase adipose tissue. And because most of our families in Arab countries, they eat a lot of junk food, and while they are treating growth hormone, they thought that the growth hormone increases their weight. The opposite, growth hormone should decrease their weight by lipolysis and increasing muscle tissue. Growth hormone, the negative side of growth hormone has anti-insulin activity, so it makes insulin resistant. That's why there is risk of hyperglycemia provided IGF-1 level is high. But if IGF-1 level is within normal, the risk of insulin resistance is little. And the most psychological effect of growth hormone, it has a positive self-esteem. So those taking a growth hormone, they feel they have a good self-esteem, and those with growth hormone deficiency, they have a low self-esteem. They always underestimate themselves. They always see they are below other people. Even they are intelligent in the school, they feel that they are not as good as other people. They have a low self-esteem. That's why when we treat them with the growth hormone enhances their positive self-esteem. When we come to the causes of growth hormone deficiency, like any other hormone, could be inherited, congenital deficiency since birth, or could be acquired. When it comes from congenital growth hormone deficiency, we have to look for pituitary anomaly, because most of the time we find that pituitary hypoplastic or structural anomaly of pituitary led to decreased growth hormone since birth. Versus acquired, and also growth hormone congenital part might be inherited. In next slide, I'll show you some of the genes involved in the growth hormone deficiency. Growth hormone could be isolated phenomena, growth hormone deficiency, or could be combined with other pituitary hormone. They found that if there are two pituitary hormone deficiency, the label will be combined hypopituitarism, while if we have more than two pituitary hormone deficiency, the term will be ban hypopituitarism. When we have combined hypopituitarism or ban hypopituitarism, we have to look for other pituitary hormone deficiency and we evaluate them every 6 to 12 months. Even the child is not symptomatic, because we might have asymptomatic one of the pituitary hormone deficiency, namely TSH deficiency, ACTH deficiency, and during the adolescent if the child had a delayed puberty, we have to evaluate LH and FSH secretion. When we come to acquired causes of growth hormone deficiency, might be due to CNS insult like trauma, infection, surgery, radiotherapy, or could be secondary to tumor. And the most common tumor causing acquired growth hormone deficiency is craniopharyngioma. Also hypothalamic tumor, any other tumors related to the pituitary stalk, nearby like optic chiasm glioma, for example, astrocytoma, all could have a growth hormone deficiency, but the commonest is craniopharyngioma. Congenital growth hormone deficiency, as I mentioned, starting from birth, resulted from either structural anomaly of the pituitary or from genetic mutation, the genes involved in the pituitary function. Sometimes we don't find any cause of the growth hormone deficiency. It's not a congenital, has nothing to do with CNS, tumor or trauma or infection, whatever. So we label the child as idiopathic growth hormone deficiency. And these are the genetic mutations causing growth hormone deficiency, like homeobox gene, SOX, BOAOF, and PROB1 gene mutation, all lead to growth hormone deficiency. So when we are, as a clinician, suspect diagnosis of growth hormone, we have to depend first on clinical evaluation of a child with short stature. So we have the child should be having a pathological short stature rather than physiological short stature. So first of all, whenever we have a child below third percentile or -2, more than -2 standard deviation below mean for age and sex, we have to differentiate. Is this child short because of physiological causes like familial, constitutional, or pathological? And one of the pathological causes of short stature is growth hormone deficiency. So from the start, we have to differentiate physiological from pathological. If we have a child with pathological short stature, we have to evaluate the growth velocity of the child. Is the child having a normal or abnormal? Of course, with the growth hormone deficiency, should have a poor growth velocity that should be below the mid-parental height, the target height, and the bone age is delayed. And then we start with the growth marker, IGF-1 and IGF binding protein 3. But to remind you, IGF-1 and binding protein 3 is specific but not sensitive. So sensitivity is about 70%. So we might have a child with normal IGF-1 and growth hormone deficiency. So we never depend mainly on IGF-1. We have to consider clinically. If this clinically the child is highly suspect of growth hormone deficiency, we have to confirm by doing growth hormone stimulation test. It is debatable whether to do one stimulation or two stimulation. Myself, I prefer to do double stimulation, 2 stimulation. And in Saudi Arabia, the cutoff level is 10. I think in Egypt, the cutoff level of growth hormone is 7, but in Saudi Arabia is 10. So whenever we have a stimulation test and the level in Saudi Arabia below 10, we confirm the diagnosis of growth hormone deficiency, and then we should start with growth hormone therapy. Growth hormone therapy nowadays, we are lucky to have a recombinant DNA technology growth hormone therapy. Before 1985, they were unlucky because the main source of growth hormone was from cadaveric pituitary growth hormone, which led to Jacob-Creutzfeldt disease. But since 1985, the community or the whole globe of the world lucky to have a technology recombinant DNA. But from 1985 till 2023, the only growth hormone therapy was available is daily injection of growth hormone. But alhamdulillah, we are lucky again to have from 2023, from January this year, we have a weekly injection growth hormone therapy. So from 1985 till now, or till early months of 2023, daily growth hormone therapy. And as I mentioned before, those with the growth hormone deficiency, they might have a lot of benefits of growth hormone therapy. First of all, improved linear growth. Number two, improved body composition by reduction in total and visceral fat and increase in muscle tissue. So the child will have more muscles and less fat. Improvement in cardiovascular function and lipid, and that is might be very beneficial for adult growth hormone deficiency. Those with growth hormone deficiency as adult, they might suffer from cardiac failure or hyperlipidemia because of growth hormone deficiency. Increased bone density, that is a great effect of growth hormone, as well as the growth hormone. It's been reported to have other metabolic effect on the memory, improve memory, alertness, and concentration to improve quality of life. And the indication of daily growth hormone therapy, when it was started in 1985, it was started with pediatric growth hormone deficiency. And then with the years, a lot of indication like chronic renal failure, adult growth hormone deficiency, HIV, Turner syndrome, Prader-Willi, small for gestation age, idiopathic short stature, short bowel syndrome, shocks, and Noonan. For the weekly growth hormone, the only, as I mentioned later on, the only indication nowadays, because it just started in the whole world, the only indication is pediatric growth hormone deficiency and adult growth hormone deficiency. So these two groups only eligible to have weekly growth hormone. We cannot so far use the weekly for Turner syndrome. We cannot use it for chronic renal failure, Prader-Willi, and other indications. The only two indications for weekly is pediatric and adult growth hormone deficiency. But the same will happen for sure with time when we have more experience with the long-acting growth hormone or weekly growth hormone therapy. For sure, the other indications like Turner syndrome, Prader-Willi syndrome, SGA will come in during the next maybe few years from now. What are the factors influencing the response to growth hormone? A lot of us as a pediatric endocrinologist, we see in our clinic that some children on growth hormone therapy, but they are not having a good response to growth hormone, and in comparison to other children who are on growth hormone and they have a good response. So what are the factors? Number one, we have to ask ourselves, what is the indication of growth hormone therapy? Of course, those with growth hormone deficiency will respond very well to growth hormone therapy rather than those with other like Turner syndrome, SGA. They might have a response, but not as good as those with growth hormone deficiency. And then we ask ourselves, what is the age of starting growth hormone therapy? Unfortunately, in our countries, most of the children present late, about 12, 13, 14. Of course, the response to growth hormone therapy will not be, as a child, started on age of 5 or 6 years of age, because the younger the age, the better response. So we always encourage, we have to increase awareness in the community of early visit to the doctor in any child with pathological short stature and early diagnosis of growth hormone deficiency because of good response in earlier age. Pubertal status, some child after puberty, starting growth hormone, of course, is not the response will be as someone below puberty, provided that the bone epiphysis is open. We cannot use growth hormone therapy in a child or adolescent with closed epiphysis. And also we have to think about growth hormone dose. Is the child taking a good dose or underdose? That's why the response is not optimum. And usually we have to do IGF-1 level every 3 to 6 months to titrate the dose, because the only way of biochemical test to know whether we are giving a good dose or not by doing IGF-1. Of course, clinical evaluation is very important. Height velocity is very important, and the site of the injection, whether the child is changing the site of the injection or not. But from biochemical level, we have to monitor IGF-1 level every 3 to 6 months in order to be sure of the dose, whether we are giving the child under dose or above the recommended dose. The adherence, this is a big problem for daily growth hormone therapy. That's why we are lucky now we have weekly growth hormone therapy. Might might getting the adherence in the right track and the weekly, but for daily growth hormone therapy, all the world suffers from poor adherence to daily growth hormone therapy. Of course, birth weight, small for gestation age might not have a good response like those with normal birth weight. Concomitant medication of the child, for example, is on a steroid because he has a nephrotic syndrome, or a steroid because of any reason, will not have a good response to growth hormone like a child without any other medication. Associated comorbidity, child with celiac, for example, with hypothyroidism, as well as growth hormone deficiency, will not have a good response like a child with only isolated growth hormone deficiency. Sometimes antibody development against growth hormone, which is very rare with the human recombinant DNA, but it could happen. That's why if a child is not responding to growth hormone, we have to think of antibody development against growth hormone therapy. And the big problem in the Arabic country is cultural beliefs. They always, the families sit together and they said, don't give your child growth hormone because growth hormone might give cancer, growth hormone might make like this, all traditional beliefs, not true. So the family will be scared from the growth hormone, and the compliance and adherence will be poor because of the cultural beliefs and the family advice when they sit together against growth hormone therapy. That's why it's very important for us as a pediatric endocrinologist to increase the awareness about the growth hormone therapy and tell the people, please don't listen to the untrue information about growth hormone therapy. Growth hormone therapy, like any medication, might have a side effect, but usually we don't see it much. Like could cause peripheral edema, carpal tunnel syndrome, but the common in our community, arthralgia and myalgia, bone pain and muscle pain is common side effect, but carpal tunnel is very rare, peripheral edema is very rare, and groin pain is common. Slept capillary femoral epiphysis is very rare. I have seen in my lifetime only 2 cases of SCFE because of growth hormone therapy. If the child has scoliosis, it will worsen scoliosis, but growth hormone itself will not cause scoliosis. But if the child is already having scoliosis and growth hormone will increase the scoliosis, gynecomastia, increase nevi size, pseudotumor cerebri. I've seen it in my lifetime in 3 or 4 patients. So it is not common. It is rare, but it could happen. That's why we have to monitor the child, especially when we start the treatment for any severe headache or diplopia, visual disturbances. And we have to warn them if they have these signs or symptoms to visit the doctor as early as possible. Insulin resistance and the risk of type 2 diabetes is very little, especially for those we monitor their IGF-1 and keep them within the normal range. That's why very important to monitor the IGF-1 level every 3 to 6 months. The history monitoring during the clinic visit, we have to ask of family whether the growth hormone is available or not. Like nowadays, unfortunately, in Egypt and Saudi Arabia, we have a limitation of growth hormone therapy because the big company Novo, they stopped production of daily growth hormone therapy this year, and we suffer from the lack or decreased availability of growth hormone therapy. Also, we have to ask about the compliance, adherence to growth hormone, any missed dose, how is the general well-being of the child, any concern about side effect, and whether or not the child is having improvement in growth velocity. And when we examine the child, we have to do accurate measurement of weight and height. We have to be sure the child is in good health, no visual field defect because of pseudotumor cerebri. The child might have a visual field defect, and we have to evaluate ternary staging of the child. Monitoring, as I mentioned, we have to monitor IGF-1 and binding protein every 3 to 6 months, and every year we have to do bone age. And when we start the growth hormone, we have to see the child 1 month after the starting therapy to be sure there is no side effect, and then follow-up 3 to 4 monthly, some people 3 to 6 monthly. Now we come to a new growth hormone therapy in the world, starting from January 2023, and that is long-acting growth hormone. The scientific name is somatostatin. Somatostatin. So far, we have 2 companies have the long-acting growth hormone. One is Novo company, and the other one is Pfizer company. What we're using in Saudi Arabia nowadays is Novo somatostatin once weekly. And what they did, that they attach the molecule of the growth hormone into the albumin. They attach it to the albumin, so the size of the molecule will be large, and then in the subcutaneous tissue it will stay for longer period, for a week. And this is the mechanism of action. Somatostatin, which is a weekly growth hormone attached to the albumin, and the first stage is bound to the endogenous albumin in the blood in reversible manner. So it is not irreversible, it's in reversible manner. And then somatostatin bind to growth hormone receptor and activating intracellular signaling, and intracellular signaling lead to increased production of IGF-1. Somatostatin once weekly, treating growth hormone deficiency. We are lucky in Saudi Arabia to be the first country in the world to use long-acting growth hormone, and that was presented last week by myself, that we give the experience, Saudi experience of using long-acting growth hormone. As you can see, Saudi Arabia in January 2023, followed by USA in April, and then in Japan, June, Europe and Canada, July 2023. So we are the first, and the first patient treated in the whole world was my patient, and I was the only and the first doctor who started weekly growth hormone in the world, and that was presented last week in SP meeting in Holland. What is the problem of daily growth hormone? The main problem is the adherence rate, adherence variable. This is a global reported adherence rate of the daily, and they found that 83% is the average of adherence rate of daily growth hormone. It varies from country to another country. And what is the problem? If there is a problem with adherence, that will affect the growth velocity. So this is a UK study. They said 23% of patients missed more than 2 injections per week. They have 41% lower of the height velocity than those on with good compliance. And in King Abdulaziz University Hospital, this is my hospital, my institute where I work, and we reported our experience to the long-acting growth hormone. Those we selected for growth hormone long-acting, as I told you before, we cannot use it unless the child have growth hormone deficiency. We cannot use it nowadays for chronic renal failure, for Turner, for other indications. The whole indication is the growth hormone deficiency. So who we selected them to be on a long-acting growth hormone: those with non-adherence patient, those who have needle phobia, those who have injection site pain, those with the family prefer to have weekly rather than daily, those with social reason, for example, divorced parents, it's better to give them once weekly growth hormone, and those in transitional phase patient. As you know, Saudi Arabia is a large country, and estimated growth hormone deficiency in Saudi Arabia vary from one region to another region, and the prevalence of childhood growth hormone deficiency reported in the north part of Saudi Arabia as the highest, and the lowest was in east part of Saudi Arabia. This is a snapshot of some of my patients started on growth hormone. We have to group either naive patients or switch patients. Naive patient, as you can see that there is in the 3 months evaluation, there is an improvement in growth velocity on weekly growth hormone, and the IGF-1 level was remarkably better on the weekly rather than daily growth hormone therapy. And this is another sample of patient switched from daily to weekly growth hormone. The same thing, there is improvement in the growth velocity as well as improvement in standard deviation. The good thing in weekly growth hormones that a child will be having once weekly, but we'll be sure that we don't measure the IGF-1 in any time of the week. We should have it after 4 days of the last injection. So those on growth hormone weekly, we cannot measure growth hormone randomly in any time. We should be 4 days from the last injection, because the studies found if we measure it in the first day or second day or from the last injection will be false high IGF-1. But in the 4 days of the injection will be a normal. If we measure it at 7 days of the last injection will be false low. So the recommendation is do it IGF-1 level correspond to IGF-1 level and day 4. So this is the only recommendation we have to tell our patient, that when they are on weekly growth hormone therapy, they should measure the IGF-1 on the 4th day of the last injection, and the recommended dose of long-acting weekly is 0.16 milligram per kg per week. That corresponds to 0.034 milligram per kg per day of the daily growth hormone. So we are starting our patient on 0.16 milligram per kg per week. To conclude this presentation, early detection and early diagnosis of growth hormone deficiency is very important to optimize adult height, to minimize the impact of any underlying health condition. Sadly, in Arab countries, especially in Saudi Arabia, most of the patients diagnosed with growth hormone deficiency late presentation because they are afraid from growth hormone therapy, so they come to the doctor very late, and that will compromise their final adult height. Pediatrician, primary care physician, and nurses should play a critical role in early identification and prompt referral for children with short stature to pediatric specialists for diagnosis and therapeutic intervention. Growth hormone therapy has a lot of benefits, a lot of advantages. The most important thing is improve linear growth, improve body composition, and decreasing fat tissue, visceral fat tissue, increasing bone body lean tissue, improvement in cardiovascular function, improve quality of life, increase bone density, and improve memory, alertness, and concentration. By this, I come to the end of my presentation. I would like to thank you all and thank the organizing doctors, Dr. Sameh, for this beautiful conference. I wish to be with you in person, but inshallah next time we'll see each other face to face. Thank you very much.
Thanks a lot, Dr. Abdelmoein. It was a very comprehensive lecture, and thank you for giving a hint on the long-acting growth hormone and your experience. Thanks a lot. We do have one of the audience have one question. It's about the IGF-1. Let me refine the question. What is the benefit of measuring IGF-1? I will refine it for diagnosis. Is it important for diagnosis and with the follow-up?
Okay, thank you very much. It's a good question.